Namaste everyone. Thank you so much for joining us today in the 37th webinar of Nepal Mental Health Research Series, and welcome to the webinar as well. So as you can see in the screen, the title of our 37th webinar, which is Strengthening Self-Regulation and Reducing Poverty to Prevent Adolescent Depression and Anxiety, the Alive Research in Colombia, Nepal and South Africa. So for today, we have Dr. Mark Jorans for the presentation in the title, and I am very happy to have him in the webinar as well. So before moving towards the webinar content, I would like to introduce our webinar or some kind of background information and reminders related to the webinar as well. So I am Binita Achari. I'm working as a senior research officer at TPO Nepal, and as usual, we have Ritika Singh, who is a research consultant at George Washington University. So basically, we are a team for this webinar. If you are joining for the first time, these webinar series are being conducted by TPO Nepal in coordination with George Washington University for the capacity building of early and mid-career mental and behavioral health researchers in Nepal. So this webinar is a part of initiative for the capacity building as well. So for the reminders, so just letting you know that this webinar will be recorded, which has been already started. So basically, the main motive of recording this webinar is to share the webinar recording to all the registered participants so that you can see it later and have some informations and or ask if you have any kind of queries in through email as well. And for that, please do fill out the registration form to make sure that you will receive the webinar materials later on after the webinar. So you can find the webinar registration form in our social media pages of TPO Nepal, or you can email us if you have any kind of issues assessing that. The second reminder is related to the webinar structure, which means the duration of this webinar would be 1 hour, which is 6 to 7 Nepal time. So after the introductory session from 8 to 10 minutes, so we will directly move to the presentation of our speaker, which would be 30 minutes. In that time, we do not interrupt our speaker. Instead, if you have any kind of queries or concerns, we we can write it down in the chat box, or you can put your hand using the Zoom app just to ask the questions, unmute yourself and ask questions after the presentation of our speaker. So means we're having 15 to 20 minutes of Q&A sessions for your ease of discussion and having the question and answer session directly with the speaker as well. After that, our speaker would be summarizing the presentation, discussions, and some summary final remarks in 2 or 3 minutes. Then we will wrap up the webinar. So we try to stick in that time duration. The last reminder is the feedback form, which we always share after the webinar, just to get informed comments or suggestions related to the webinar to plan the further activities or other events going forward. Just a quick information that these webinars are being conducted in the third week of every month, except Dase and PR break. The invitation email will be sent out with the speaker details to our network members who are already the members of Nepal Mental Health Research Network. So beside that, the other informations are updated in our social media pages, Twitter, Facebook pages. So if you have any kind of additional informations or queries, you can directly email us to our amateur and email address as well. So for now, introducing our speaker, I would like to request Ritika Singh to go ahead with that. Thank you.
Thank you. Thank you so much, Bintaji. And just to mention that this is likely to be our second last webinar as a part of the Nepal Mental Health Research Network series. And for the second last webinar, we have something very special in store for you. It is an absolute privilege to be able to introduce Dr. Mark Jordans and to bring down the extent of the work that he has done globally and in Nepal in a few minutes is next to impossible, but I am going to give it a shot anyways. Mark Jordan's PhD is Professor of Child and Adolescent Global Mental Health at the Center for Global Mental Health at King's College London, and Professor of Child and Adolescent Global Mental Health at the Amsterdam Institute of Social Science Research, the University of Amsterdam. He is a child psychologist and works as Director of Research and Development for the NGO War Child in the Netherlands. His research interests are the development, implementation, and evaluation of psychosocial and mental health care systems in low and middle income countries, especially for children in adversities and in fragile states. And we've had the privilege of working together with Mark also in a lot of mental health interventions in Nepal and in a truly global scale. Let me welcome you, Mark, to our webinar, and the floor is yours.
Thank you so much, Ritika and Benitaji, for the introductions and setting the scene. Namaste, everybody. Really nice to see you all. Thank you for making the time. I know everybody is busy, so it's really nice that you're taking the time. And it's also very nice to see some familiar names and some colleagues and friends on the call. So I am excited to be talking to you today about some recent work, but let me first share my PowerPoint. Which should be visible to you now. Yeah, is this, can you see it okay?
Yes, Mark.
Excellent. So, yeah. So I am excited to talk in any case about any mental health work in Nepal. I've been working with TPO Nepal from the start and from its inception. But especially about this program, which is all focused about essentially the prevention of adolescent depression and anxiety. And I will introduce a little bit the importance of taking a prevention approach, and then going into some detail about what this live research program is all about. And it takes place in Nepal, but also in Colombia and in South Africa. But let me start from the start, and some of it I'm sure is known to many of you, but still important to position the work that I'm talking about today. And this is that 90% of the 1.2 billion adolescents globally live in lower middle income countries. So it's not something that is on the side. No, it's actually a primary importance to look at lower middle income countries by the sheer size of where adolescents live. We also know from extensive research that the combination of depression and anxiety, or common mental disorders, contribute to as much as 34% of the years lived with disability among young people. So this is really kind of the disability that is caused by mental health conditions. And in the graph on the right side, you see kind of that for many of these conditions, you see kind of a peak in that late adolescence and maybe early adulthood for a lot of the disorders. So it's really an important period, especially late adolescence, for the onset of mental health conditions, including depression and anxiety. And that's why it's important to look at adolescence, to really be as early on as possible in detecting and tackling something like depression and anxiety. But also, not just because the onset is early in the life course, but also because we know that adolescent depression has predicts adversity downstream in the life course of those adolescents. So just to name a few, but there's strong evidence for adolescent depression to be predictive of dropouts in secondary school, unemployment, increased poverty, unplanned pregnancy, or unplanned parenthood, for later mental health problems, and even chronic health conditions. All of these have been linked to adolescent depression. So again, it's really important to act early on in the life course of children. So I'm going to also, again, to position this work, is to look at, well, what is the evidence base that we have when we're looking at, I mention here children, but we are focusing mainly on adolescents, but sometimes I use them interchangeably. The evidence base for psychological treatments is actually pretty positive in lower middle income countries. If you look now, there's many studies that have gone into evaluating psychological interventions in lower middle income countries. In fact, there's the latest review in 2022 showed 43 treatments showing positive results, and these are all randomized controlled trials, so the highest level of evidence, if you like. And so that's really good news. If you looked at 10 years ago, we had much more mixed evidence base, but the evidence base is pretty solid for treatments for children, adolescents in lower middle income countries. It's important to keep in mind, though, that this review takes into account that this is treatments done by professionals and non-professionals. So it's not just task sharing models. And that there's also quite a mix of quality of studies. So some of the studies are not are maybe not as good as others. Still, the overall trend for treatments are positive. Then, if you're looking at the evidence for specifically for depression, so the previous slide was for any psychological treatments. If you're looking at specifically for depression treatments, and again looking at lower middle income countries, again we see that the overall effect of all the randomized controlled trials that were conducted, and the latest I think is in 2017. A review, it shows again that the evidence for depression treatments is positive in lower middle income countries. So we and all of these are task shifted models of treatment. So all of them are by non-professionals, non-mental health professionals. So again, that's good news. We've got good news for treatments for children and adolescents, for psychological treatments, and some good news for depression treatments specifically. However, and this is where the big however comes, all of this work, as you noticed, was on treatments, both this one as this one. Where there's a big gap is looking beyond treatments. And this is quite a famous kind of spectrum that shows mental health treatments that range from, on the left side, promotion, all the way to treatment and recovery. And again, all of the evidence that has been generated, the majority of that sits in that treatment part of this pie, of this spectrum from mental health promotion to treatment and recovery. There's much less known about promotion and prevention. And again, just if those terms are new to people, mental health promotion is all about creating positive outcomes as a result of an intervention. And generally that is for the population at large. So that might be improving well-being, or it's improving other positive aspects of mental health. And then the prevention part is essentially preventing the development of mental health conditions in a population that is not yet has not yet been diagnosed, or that has not yet developed a mental health condition. So this is for people that do not have depression or anxiety yet, but might be at risk of developing depression. And you have different ways of prevention, and I'll go into that later, to avoid these people from developing depression. And then the treatment and recovery on the other side of the spectrum. And all I'm trying to say is that a lot of the evidence that has been generated is positive, but it all sits on that treatment and recovery side, and very little on that promotion and prevention side of this spectrum. So the case that I and we as a team are making is that we need to really look beyond treatment only, and also embrace prevention interventions. Because we know that if you're looking at that burden that depression and anxiety create, the 34% of years lived with disability that I mentioned earlier, we know that treatments alone can only reduce that burden by about 1/3. And that's even under optimal conditions. So we need to do more to really bring this burden down. And essentially, the argument is if we want to improve population mental health, so the overall mental health of adolescents, for example, in Nepal, we need to have a treatment and prevention and promotion approach rather than only one of them. And that's why it's so important to also look at prevention work. So what does prevention work really, what does it mean? And it basically means that you tackle some of the big risk factors that contribute to having somebody having a larger chance or a risk of developing depression, anxiety, or other mental health conditions. And those are often summarized under what we call social determinants of mental health conditions. So social determinants basically refer to the social and economic conditions that influence on the prevalence and severity of mental health disorders in people across the life course. So these are conditions that we're all familiar with. This could be issues of poverty, of marginalization, of being exposed to traumatic events or other life adversities. And we know that those are risk factors that predict developing depression and anxiety. So if you can address these social determinants, that's a way to also go about preventing the development of depression and anxiety. And especially if you can address some of those structural or systematic social determinants that create the biggest disadvantage for people. So that's one way of looking at prevention, is by tackling some of the social determinants of mental health conditions. And I would like to point you to I think a very nice review by my colleague Professor Craig Lund, and we also run the Alive project together, who did a review of all those social determinants for which we have evidence to be linked to mental health conditions. And that review, as you see at the bottom of the screen, was published in 2018. And it can be mapped onto these different domains, on demographic domains or on environmental domains, on the neighborhood and social and cultural factors, but also, and importantly, on economic factors. And that's what I'm going to zoom in on today. So issues of poverty is actually one of the biggest and most recurring and strongest predictors of developing mental health conditions. So it's one of the most important social determinants if we want to take a prevention approach, because issues such as income and debt and financial strain or unemployment, economic inequalities, all of these aspects, as you can imagine, are strongly predictive of developing depression. And that means that it gives us a way to address the prevention. And that's what we are going to look at in the Alive program, is to really look at the social determinant framework, but especially on the economic one. Now, as I mentioned earlier, the evidence that we have was looking good for treatments. And then I said we need to look beyond treatments to also look at prevention work and the reasons why. Now, what is the evidence that we have for prevention intervention? And actually, this is not so good anymore because there's been very few studies conducted, in fact. If you're looking at all the depression prevention studies conducted globally, only 6% of these have been done in lower middle income countries, even if the majority of people, as we all know, live in LAMICs. So only 6% of the studies are done in LAMICs, and those that have been done are not giving us a very strong evidence for the effectiveness of the interventions, of these prevention interventions. So really, there's need for a lot more research to be done on prevention intervention for depression, and especially among adolescents. So that's the gap that we're jumping in with the Alive program. Now, it doesn't mean that there is nothing. There's some really good guidance out there from the World Health Organization and UNICEF that have consolidated and synthesized what is the best practices and the guidelines on promotion and prevention interventions for adolescents. And it's basically under the Helping Adolescents Thrive program and the Helping Adolescents Thrive toolkit that you see on screen, where there's a very good collection of some best practice work and some guidelines on how to go about it for people that are interested. But not a lot of this has been evaluated and researched. And that brings us to maybe a summary of the key gaps in our knowledge. So there's really a big gap in the evidence for prevention interventions overall, but especially for children and adolescents, and especially in lower middle income countries. We also, I mentioned that we know there's strong evidence for the link between poverty to mental health. And in fact, it's a bidirectional relationship. So we know that increased poverty leads to increased mental health problems. But we also know that people that have more mental health problems will experience a greater amount of poverty. So it's a bidirectional relationship. That is known. What we don't know yet is what are the mechanisms by which poverty creates those increased mental health problems. So understanding those mechanisms better also allows us to intervene better. So that's the second gap. The third gap is, what do you get if you have an intervention that combines an approach that tackles poverty as well as mental health or psychosocial aspects? And what happens if you combine these two? So there's been a lot of evidence and research in mental health interventions alone, quite a lot on economic interventions alone, but not for combining these two, and again, especially not for children and adolescents. So these are the main gaps in our knowledge that we are jumping into with the ALIVE program. And the ALIVE program essentially stands for Improving Adolescent Mental Health by Reducing the Impact of Poverty. So this is happening, as I mentioned, in Colombia and South Africa and in Nepal. And we are wanting ultimately to reduce and prevent depression and anxiety, but for a population that lives in poverty, because that is that big risk factor and that social determinants that we want to where we want to intervene. So that's the program. We've got a couple of years. It's a 5-year program supported generously by the Wellcome Trust. And this is just very briefly some information. Of course, you all know about the situation in Nepal. I think most of you do, at least. But also some basic information of South Africa and Colombia. But especially maybe the last two columns of getting a sense of the size of the population, but also our best estimate prevalence rates for depression and anxiety in each of the countries. Again, we all know that this needs to be taken with a bit with a grain of salt, because it depends on the quality of studies, but it gives us an indication. Now, I'll spend the last part of the talk on talking you through the program, and the program has 4 objectives. One is to develop a theoretical model on those causal mechanisms, how poverty links to increased mental health. And we are hypothesizing that self-regulation is in that is part of that theoretical model. 2, we want to develop a modular intervention to address the impact of poverty. 3, we want to adapt and validate instruments to be able to do that, and then to conduct a pilot randomized controlled trial. Now I'll give you a brief overview of all of these and what we're doing. Here's the first one, and maybe the summary of the ALIVE program. basically what we're saying, and it looks more complicated than it is. Basically, we are saying we know that poverty on the left side of the screen leads to an increased incidence or prevalence of depression and anxiety. And what we are hypothesizing is that that relationship is mediated or is explained by what we call self-regulation. So people and adolescents that have more poverty experience more difficulty with self-regulation, and because of that difficulty with self-regulation, have a increased risk of depression and anxiety. And because of that, if that's our hypothesis, the intervention, one should then focus on both the poverty element as well as the self-regulation element if we want to improve that depression and anxiety outcome. And that's exactly what the Alive program looks at, is targeting that combination of these two factors, which is what I was mentioning as one of the gaps in the literature. Now, what is self-regulation? Very briefly, there's many definitions, but self-regulation is essentially the motivation and capacity to use executive functions to achieve somebody's one's goal, an adolescent's goal, or your own goals. So it allows you to set goals. It allows you to create the motivation to achieve and to pursue that goal. And it allows you to get the capacity and the abilities to keep that goal in mind, to monitor the progress, and to really get yourself towards achieving your goal and all the cognitive functions that are part of doing that. So that, in short, is what self-regulation is about, is that you're able to set motivate yourself to achieve a goal and creating the capacity and the functions to achieve that goal. And because you're in extreme poverty, those functions are maybe under pressure. We know from the literature that low self-regulation in childhood and adolescence predicts again poorer health. It predicts other negative outcomes in adulthood, from poorer health, and financial problems, child rearing problems, and even criminal convictions later life. So we know it's an important factor. Now, and that's why we are taking that self-regulation as part of our theoretical model, and we're checking that by doing a review of the literature, but also by doing qualitative research in each of the countries to test that theoretical model. And indeed, we've conducted that, and we have found and looked at what self-regulation strategies are being used by adolescents already, so that we know what we're looking at. And these are on the screen some self-regulation strategies that have been reported in the work in Nepal, but also South Africa and Colombia. I won't go into too much detail here, but just to give you a sense. Then we get to the intervention. Over the last years, we've actually developed an intervention, like I said, that tackles the economic and the poverty part, as well as the self-regulation part. And each of these consists of different skills, if you like. So on the economic part, we're working on information to know about the importance about education and how to go about financing education, and even going about job training, to also going into financial training skills itself and negotiation skills. So all of those parts make up the economic intervention, including a cash transfer. So adolescents and family members actually getting cash in hand as part of the economic intervention. The self-regulation intervention is more psychosocial in nature and focuses on issues as emotion regulation or cognitive regulation, goal setting, as I mentioned before, physical and social activities, and other interpersonal aspects. Again, I'm not going into a lot of detail. It's just to give you a flavor of what the intervention does to address both the economic and the self-regulation aspects and that I mentioned before. What is important to mention is in the self-regulation, the physical activity is an important element. So in Nepal, that meant doing martial arts. In South Africa, that meant doing surfing on the sea. And in Colombia, that was skateboarding, because through those physical activity, you really also master some of those self-regulation skills. In the economic side, the cash transfer is really an important element, because a lot of the financial training and information and negotiation skills are really to make sure that the cash is spent in the best way possible. So those are things that stand out in each of those parts of the intervention. Now, this is an overwhelming slide, but I'm not only to say that that third objective is really to look at what instruments and research instruments do we need to develop, adapt, translate, and validate in order to evaluate this intervention. And really, it's a whole set of interventions that we're looking at. And but maybe I will come back to the most important one. What is important to know, I am in my last minutes, but I think I should be okay making it. Is that this is like I said, the intervention is a prevention intervention, and it's an intervention that targets children that have a risk of developing depression. So because we really select adolescents that have high levels of poverty, but they have not yet developed depression symptoms. That's the exact group we are targeting, and we call that in the literature and in that spectrum that I showed before, that's what we call a selective prevention approach. Now, for that group, that's the group we are selecting into our study. So it's children and adolescents that you see in the top left that have a high risk of developing depression, but are not yet showing symptoms of actual depression and anxiety disorder. Those get selected into the study, and ultimately we want to evaluate whether children that were not yet depressed do or do not develop depression and anxiety before and after the intervention. And we want to see that the control group, which is the fourth arm, there's a four-arm trial, the control group would essentially develop, the children or adolescents in the control group would essentially develop more depression than those in the intervention group. And in the intervention groups, we have three. We're actually looking at the intervention arm that has a combination, the poverty reduction or economic, as well as the self-regulation, as well as one arm or intervention that is only doing the self-regulation part, and one arm or group that does only the anti-poverty or the economic intervention. And this allows us to answer that other gap in the literature to say, is the combination of these two approaches the best way to reduce depression and anxiety disorders, rather than one of these two approaches alone? Now, that's where we are. Just maybe really important to say that throughout all of these stages, we've really had adolescents engaged in the research. So we had adolescent advisory groups in each of the countries that were very active in helping us through the study preparation and conduct. And really just to give you a snippet of where we are now, we've just completed the 4 arms. So these 4 arms were followed before and after, and all the interventions were implemented in all 3 of those intervention groups: self-regulation alone, economic alone, and combined. And that consisted of 20 sessions for each of these groups. And you see in total, we've got about 625 children or adolescents, enrolled in Colombia, Nepal, and South Africa combined. And we will follow them up another 6 months and 12 months after the study is completed. And then we will get to the evaluation in order to determine next steps. But let me not take too much time so that we have enough time for questions and discussion. So I hope I wasn't rushing things too much, but if so, you can always just ask and I can go back to it. So I'm gonna maybe just stop sharing the slides here and hear from you, Ritika, and Benita, back to you or to
Yeah,
question.
wonderful presentation, Mark. And no worries, you are exactly on time. So if you have time later on, we can also discuss in the slides as well, or you can discuss in the summary as well. So now, so everyone will be moving towards the Q&A session. So feel free to unmute yourself and ask the questions you have, or we already have question from Ritika ma'am. So you can facilitate the Q&A and ask your queries to be more clear. Thank you.
Sure, sure. Thank you, Bintaji. Okay, I'll be facilitating the Q&A session. If anybody sorry, just before we go in and before I ask my question, if anybody has any concerns about asking a question in English, feel free to type it in Nepali. We're happy to provide translation services as well as we go along. Feel free to just raise your hands. Feel free to write your questions in the chat box, whatever works for you. Mark also understands some Nepali, so we know that we will not be communicating in Nepali, but then there are not going to be any barriers in communication in this webinar. Um, while our participants gear up for questions, Mark, I was very curious as to what the cash transfer programs looked like. For example, like how was it determined that how much cash is going to be transferred? How was it transferred? Were there any regulatory mechanisms in place as well?
Yeah, great question, Ritika. Thanks a lot. So yes, the cash transfer is I should say is building on quite a lot of evidence out there already on cash transfers as a strategy to tackle economic constraints. So it's building very much on that. And what we have used is a threshold for what is meaningful, what is a meaningful amount. And that's basically a percentage of a household income in each of the countries. So we've taken an average household income and we are providing a specific percentage of that so that it is of course not a full, it cannot be a full household income, but it can also not be too small that it's not meaningful. So it's a percentage of an average household income that then is given as a cash amount in hand to 2/3 of it goes to the parents and 1/3 goes to the adolescents, so that adolescents themselves also have some of that empowerment and learn some of the skills to that comes with the cash. And it is what is called a unconditional cash transfer. So there's actually no strings attached. So the families and the adolescents and caregivers themselves can determine how to use it. And I say that because there was a lot of research done on what is actually better, that you say here's a conditional cash transfer, so here's an amount of money but you have to spend it on the education of your child or you have to spend it on food, versus here's unconditional because you as a family know best how to spend it. And the evidence has shown that the unconditional transfer is better because families themselves can then use it where they see the biggest constraints, the biggest financial constraints. Is it to relieve debt, or is it to pay for fees, or so the family themselves can determine it. So that's the mechanism, Ritika.
Yeah, I mean, I can understand that there must have been like a lot of back and forth on this because it is quite sensitive. And I think all our work, there is always this aspect of sustainability. And I was very impressed to see that in your the poverty reduction side. It was not only cash transfers, but also like going back to school, discussing employment opportunities, for example, and so on and so forth. So yeah, that's very insightful, Mark. Thanks. I see there is also another question. Thanks, Mark, for an excellent presentation. Of course, it's from Navraj Upadhyayji. I'm interested to learn more on how parents, caregivers are engaged, involved in a live program. What is expected of them in terms of their time investment or activity involvement?
Yeah, thanks. Hi, Navraj. Really, I saw your name already. Really nice to see you. Um, yeah, that's again a really good question. Because we have so much evidence for if we want to improve adolescent mental health, that the family and especially the parents play such a crucial role in this. So we decided, as you saw in the self-regulation arm, but also in the economic arm, both of these have aspects that focus on the adolescents and on the caregivers. If I look at the self-regulation one, that's really looking at two aspects. In other words, on the one hand, it's parental well-being and looking at stress reduction for the parents as well, because we know that if parents are stressed, if they are not, taking care of their own emotional well-being, that translates back to their children and their adolescents. So it's looking at their well-being, and it's looking at their parenting styles, and specifically on the relationship adolescent and parent. Again, because that's a known factor of improving children's mental health. Concretely, it means 6 sessions that so where the adolescents get 20 weekly sessions. This is the parents get attend 6. I also will say the flip side of this. The flip side is that it actually makes it for quite a complex intervention. It's already rather long. It's already quite difficult to have economic and self-regulation combined into one intervention. So also addressing the caregivers or the parents makes it even more hard. So one of the things that we are testing now, if whether it's feasible to have it focus both on the adolescents and the parents. So from a conceptual theoretical point of view, there's a lot of reason to do so. But we need to also look at the feasibility, and that's one of the things we're testing at the moment. And Avraj, yeah, feel free to jump in if you or anybody else have further thoughts on that. I'd love to hear.
I think there's a quick follow-up question, Mark. Are caregivers regularly attending the sessions as well? From Navraj.
Yeah, thanks. So we've actually it's pretty good, but not as good as the children. Let me just grab the numbers. I had them right there. So if you're looking at caregiver engagement in Nepal, because that's our I think most of us on the call, we're looking at 66% for the self-regulation only, and much higher for the other ones. It's around 90 and 85% for the other two groups. Now, that's because when there's a cash transfer involved, I think it does increase attendance. And so 66% for the group that has only self-regulation. So that's lower. And I should say that we are struggling, especially in Colombia and South Africa, to get those parents involved in the non-cash transfer arm. So it is really an issue, and that's why we're saying we need to look at whether it is worth it and whether it is feasible, because attendance is lower, especially in the other sites. In Nepal, it's still really decent.
This is extremely interesting, Mark. And I think you also mentioned somewhere that all adolescents have at least 20 sessions, and parents attend, or parents or caregivers attend at least 6 sessions.
Correct.
Yeah.
Yeah.
So that was there as well.
Yeah.
Yeah. If Navraji, if you have any follow-up questions, please feel free to go ahead. But then for now, we will move on. There is another question from Sauharda. Are there plans to follow up the adolescent participants in a long run? Any hypothesis on what it looks like in both mental health and economic independence terms?
Yeah, thanks, Arhara. Nice that you're on the call. So yes, so we are following them up before and after the 20 weeks, right? And that's where we are at now. But then we follow them up again 6 months after the end of the intervention and 12 months after the end of the intervention. So that's a pretty long time. Um, and importantly, and that's why, Sahar, I'm happy you're asking, we're actually saying we are mainly interested in what it does at that 12 month after the intervention, so 1.5 year after baseline. That's when we want to see a change between the group, and we want to really evaluate the effectiveness. And that is because, again, this is not a treatment trial where you want to see that symptoms have reduced after your intervention. We want to see that because participating in this intervention reduces the likelihood of adolescents developing a depression over time. And that's why our primary outcome, our main outcome, is to see how many children that did not have depression develop depression over time. And for that, we want a longer time frame. So our primary outcome is actually 18 months after endline. After baseline, apologies. So 1 year after the intervention. You could, and in our future study, we would even like to look beyond that, but we only want to do that if we have an indication that the intervention is effective. Then it's also worth looking even longer. So, Hara, I don't know if that answers your question. But...
So Harda, I don't know if you're going to be able to mute yourself. I know you're commuting, but then if you have any follow-up questions. Oh yeah, yep, thanks, great.
I got a smiley.
um, there are few other questions as well, Mark. So this question is from Mansingh ji. Was there any understanding on emotional and behavioral problems, including ADHD, among adolescents, especially in the context of Nepal?
Yeah, nice questions, everybody. Really nice. So, no, the short answer is no. We're not tackling ADHD specifically in this program, and quite frankly, in none of our programs that I've been involved in Nepal. So it's really an interesting piece. What we are including is kind of more broadly behavioral problems. So what are behavioral problems that children demonstrate? So that could be, it does involve some attention, difficulties with attention and attention span. It does include issues of irritability and in a higher levels of frustration, and even getting into conflict or fight. So those things we are including as part of let's say a behavioral problems scale, but not specifically attention deficient ADHD, because that yeah. We don't have an adequate scale, and also hasn't been included.
Got it. And also another question, also when you say urban slums, does it also count squatters areas?
Yeah, nice. Actually, we're not in the squatter areas or in the informal settlements in Nepal. We've been going back and forth on this when we were designing the study, and I don't know if any of my colleagues are on the call, but we were initially thinking to do it in informal settlements, but then moved away from that to also include areas where we know that in this case in Kathmandu, where we know that there's a higher level of or a higher risk of poverty, but where not necessarily everybody is experiencing high levels of poverty. So in Nepal, different from than in Colombia and South Africa, we developed a very short screener to get a sense of indeed to what degree adolescents are experiences or households are experiencing what we call multidimensional poverty, which is one way of looking at and operationalizing poverty. So we've developed a short instrument screening assessment to say, okay, well, what adolescents live in households where we see high levels of screening, also in normal normal, of course, between inverted brackets, schools that are not in the informal settlements. And we did that for two reasons. One is because the informal settlements are of course large in Kathmandu, but not at all as extensive and as large as for example in places such as Colombia and Cape Town and other countries. In Kathmandu, there's a lot of poverty that is also in the formal urban settings, and we didn't want to exclude that. So we were really taking that approach for that reason.
Thanks, Mark. We have another question from Pratiksha Adhikariji. I would love to know if you have examples of increased self-regulation on teenagers resulting to their relationship with their parents.
Yeah, no, so that's yeah, wonderful questions, everybody. I'm really enjoying this. No, but that is our hypothesis, and it goes back to Navraj's question before, including that parent and that adolescent parent relationship part is in our thinking an important aspect. Because we know that there's a relation in other studies, but we want to now test that. So we want to actually test to what degree does self-regulation and maybe increased self-regulation also impact the caregiver child or caregiver adolescent relationship, and to what degree does that then predict improved mental health outcomes. So by having all of these factors included, and indeed we are measuring. So we are measuring self-regulation, obviously, but we're also measuring those parenting and parent-child relationship aspects in the study. So we were actually able to see how do these relate to each other: self-regulation, parenting, and psychological outcomes, and down the line. So we would have information and data on that because that is exactly what we're hypothesizing to find. It's a great question again, really nice.
Yeah, we'll have to keep watching, waiting and watching for all the outputs that come from this.
I know it's such a bad presentation in that sense, right? I can only say, look, here's some thinking, here's some work, but I have no results. It's terrible.
Honestly, Mark, this is like so insightful, and we already have some more questions as well. Can you also share challenges if your team encountered any while doing research in informal settlements, especially Kathmandu metropolitan city trying to dismantle slums and informal settlements?
Yeah, so important to say that we're really not exclusively working in the informal settlements for the reasons I mentioned before. I think some of the challenges, though, nevertheless, that we're facing are I think again, Navraj pointed to it before. I think the attendance of caregivers, even if higher than South Africa, Colombia, is still low, and I think that's an issue. The second challenge that we're seeing is the duration of the intervention. We're going for 20 sessions. Now that is long. And then I think for many of you that know some of the other treatments and other interventions that we are implementing, they're often shorter. So 20 sessions is long. But we're doing that purposefully. We're saying if you want to intervene on how poverty affects depression, it's not a quick fix. It's not actually a as clear as a treatment where you can focus on symptoms and symptom reduction. So we're saying we need a longer period to change those mechanisms. But it makes for somewhat of a challenge, is how do you keep adolescents engaged for 20 sessions, and is that feasible? How does it fit in the school schedule? How sustainable is 20 sessions? And I think that's really a challenge. The last challenge I would like to point out is that, especially for Nepal, is the cash transfers. It's how do you go about cash transfers? We're given cash in hand in Nepal, but in other places, it's better to do it via a transfer in banks. But we weren't able to set set that up. Many people didn't have bank accounts, or we couldn't set them up, which is understandable. But that was a challenge. And another challenge is that in Nepal there is no nationwide a cash transfer program, which in South Africa, Colombia, and in fact many low-income countries, there is government-supported cash transfer programs that are run nationally. So it kind of matches the national policy on that. And in Nepal, that's a little bit to a lesser degree. So we're not building on existing kind of infrastructure or policy in that sense. So those are some of the challenges that we're seeing.
That's very insightful, Mark. We're winding down. One of the last questions we have is from Sujan. It might already be answered by Navrat sir's question. Guardians might support the study due to economic incentives, but I'm still curious about caregiver reactions and influence over adolescents' participation in the intervention. Do you have any additional points?
Yeah, so I do have a couple of additional points. So the first is we need to unpack, of course, what parents' motivation is to join, and I think that we don't know enough of that yet, because we think that this is the cash transfer because we see so much higher participation in the cash transfer arms or the economic arms or the combined arm versus self-regulation only. But what is important to say is that it's getting guardians and caregivers and parents, getting them in is what is the issue. And we see that actually so often also with getting men to participate in kind of parenting intervention, is getting them in. Once they're in, we see that they're pretty well staying, and many of them stay for all of the 6 session in our case. So the barrier that we're seeing is getting them to come in the first place. And that is easier with the cash transfer rather than the self-regulation only. But once they're in, they seem to be very happy with the material and the discussion and the sessions. Also in the self-regulation only, they like the focus on their on the well-being. They like the focus on the adolescent caregiver relationship and discussing that in group. So I think the main point, Sujan, so thanks for bringing that up, and nice to see you as well, is to get the caregivers to engage. Maybe last point, if you allow me, Ritika, if I look at some of our other interventions that is focused on caregivers in other countries where we're exclusively focusing on caregivers and guardians and parents, we actually see that it isn't so hard to get them in and to keep them in. I think here the difficulty is it's a little bit of it's in addition to what is primarily an adolescent-focused intervention. And I think it might also reflect a little bit that we might have not given it as much attention to focus on the families and the caregivers as we did to the adolescents because of that. So it might also be reflective a little bit on where our focus has gone as a research team, as a program team. Because in other parenting and family interventions, we do get caregivers to come in and stay in pretty well above the rates that we're seeing here. So those are a couple of reflections to Sujan's great question.
That's wonderful, Mark. Thank you so much. And we're absolutely at the end of our webinar, but just wanted to ask if you have, like, the findings are pretty specific, right? Self-regulation and economic activities in the pilot trial is working in case of adolescents. But do you have any key takeaway for us that you would like us to have at the end of this webinar?
Yeah, I can be very short. We're at time, but it's also, I really think it's really short. I would say prevention is important. I think as a global mental health community, we focused a lot on treatment. We've gotten very far. It's time that we shift the focus to prevention because there's a lot to be gained from prevention approaches. So that would be my one sentence.
Thank you. Thank you so much, Mark. We're getting a lot of thanks in the chat as well. Bintaji, is there anything else?
No, I'm so happy that we really had an interactive session, and thank you, Mark, for your time. We really appreciate your time and effort for this webinar and sharing your knowledge and expertise with us. And it was a pleasure hearing for you, to be honest. And thank you so much, Ritika ma'am, for your support. And I'd like to thank everyone for being in the webinar as a participant and making this webinar successful. And like, to be honest, I'm not accepting the fact that I'm not mentally prepared to accept the fact that this is the second last webinar and the next webinar would be the last webinar of our network. So never mind, we will be presenting other event as well. So thank you so much. See you in the next webinar. Thank you so much, Mark. Thank you so much, Ritika ma'am.
Thank you, everybody.
Bye-bye.
Thanks a lot.
Thank you. Thank you, everyone. Thank you, Mark. Thank
Bye.
you. Bye-bye. Thank you, Vintaji. Bye.
Bye.